Let's talk about the irritable bowel syndrome. Definition of irritable bowel syndrome is abdominal pain that is not really explained by a organic finding. So there is no structural or anatomical finding that can explain the abdominal pain. It's a very common chronic functional disorder, and it generally causes intermittent pain and discomfort. And there is a relation generally to the stool pattern and bowel movements. Generally, people have these symptoms for many years. It's very often that starts early in life, in teenage years, and we know that it is more prevalent in females rather than males. Now, irritable bowel syndrome, when we talk about, we generally talk about diseases that are related to the large intestine and colon, but it falls under umbrella of the functional disorders of the GI tract that can affect anywhere from the esophagus all the way to the anus. There are other conditions in the esophagus, stomach, and bowels that can cause these kind of non-specific kind of pains without any organic finding, and those are considered functional pain in general. When we refer to IBS or irritable bowel syndrome, it is more well known and it is very much used interchangeably. But if you want to get to the science of the GI tract and functional disorders, we have functional dyspepsia, biliary dyskinesia, and other subtypes of functional disorders that are not IBS, but very frequently by the patients or even by the physicians, practitioners, it has been referred as irritable bowel syndrome. Depending on which area of the universe, of the world you look at it, anywhere from 10 to almost 30% of people can have it. In the US, it's around 10 to 15% is what we generally talk about. It can affect any age group, although it is more common, as I mentioned, in females and earlier in life, less than age of 35. But there are instances that later in life we find people that having these functional disorders. It is the most common cause of seeing gastroenterologists and primary care physicians, and second highest cause of missing work. It is not a cheap disease. It costs our healthcare system anywhere from $2 to $8 billion because of the days missing work or testing and investigation and treatments. So it generally starts with abdominal pain. There is usually a pattern of changes in the bowel habits, generally constipation, however, diarrhea is common too. Bloating and abdominal distension, excessive passage of gas or flatus, bloating, the feeling of individual needs to use the bathroom immediately when they have the urge, the urgency of bowel movements, and quite often after using the bathroom, they feel that they were not able to completely evacuate their colon. Generally, after bowel movements, in the true definition of irritable bowel syndrome, the pain is relieved after bowel movements. So to make it more attractive and make it easier to digest, let's start by a case. DV is a 31-year-old female, comes to my clinic with abdominal pain, discomfort, and bloating. She indicates that this is intermittent, generally worse during working days, on weekends, and when she is off, she doesn't have as much problem, has been going at least for 6 months. She missed many days of work, and she works as an administrative assistant, and also she's suffering from fatigue. So first thing that goes through our minds as practitioners when we having a patient with these presentation is to make sure that there isn't anything more concerning, warrants, investigation. And generally, we refer these to these signs and symptoms as alarm symptoms: anemia, low blood count, having fever, persistent diarrhea, rectal bleeding, even the white kind, as some people would like to call it, meaning seeing blood after wiping on tissue. And weight loss are some of those major alarm symptoms that we always try to extract and know about them, because they generally mean that there is more to the story, more than just irritable bowel syndrome. And some of those things that can mimic irritable bowel syndrome, but there are not, are malabsorption situations such as celiac disease, which is because of gluten intolerance, and allergy, and lactose intolerance, dietary factors, infections, colon cancer, inflammatory bowel disease such as ulcerative colitis and Crohn's disease, some gynecological disorders such as endometriosis, psychological disorders, and other immune-related disorders such as eosinophilic gastroenteritis are some of those big ticket items that we always try to eliminate, and is in our differential diagnosis before labeling somebody as having irritable bowel syndrome. So going back to our patient, she eats irregular and often in a hurry. She's anxious about her symptoms and worried that maybe she's having more than just irritable bowel syndrome, especially because her grandma had cancer. She's wondering if she might have colon cancer. Very stressful lifestyle. However, on questioning, she denies any blood in the stool or diarrhea, mainly she's constipated, and no change in body weight. She's not losing weight, and she indicates she's eating well. So, one of those biggest things that we talk about with patients and we have to try to get out is what is the main reason and what is that is most they are worried about. Fear of cancer is up there, but there are people that think they might be crazy because they have been to many doctors and many tests and nothing showed up. Is it all stress? I'm feeling much better during the weekends. And at the end of the day, can you do anything to take my symptoms away? So, what we do for diagnosis, obviously, physical exam and history plays a major role, but those are mainly to rule out the other conditions. We rely heavily on the patient's symptoms and try to make the diagnosis by making a good history and physical exam. But there are situations that we have to look into some of those other conditions, especially if there's an alarming symptom, to make sure that there isn't any confounding contributor to this situation. Treatment is usually through, there are three main buckets for treatments. We talk about dietary changes, psychological factors that can affect the individual and targeting those, and there are some medications that we try, and those medications can be some nerve modulators to help with the symptoms and pain, or basically adjusting the individual bowel movements. Generally, research shows that if there is a good relationship and trust between the provider and the individual, there is better outcome. They need to come up with coping mechanisms and also things that individual can do to cope when they have the flare or their symptoms are worse. We generally very much emphasize on patients, have them tell us what is going through their mind, if it is fear of cancer, if this is just pain related, and trying to address those. And we very much encourage keeping a diary as far as their symptoms and try to correlate those with the diet and the stress, the amount of the work, and trying to find out some of those triggers that makes their symptoms worse. So going back to DV, she says that abdominal pain and bloating are relieved by having a bowel movement, and she's usually constipated and she takes laxatives. On her exam, bowel sounds are fine. There are just some abdominal pain, not a specific abdominal pain, and on vital signs were good. General labs, just blood counts, did not show anything abnormal. So when we come up with this determination that this is very much compatible with irritable bowel syndrome, we are not dealing with any other major other medical condition that are mimicking irritable bowel syndrome. We very much start by trying to know more about the pattern of the pain and bowel movements, because adjusting the bowel movements plays a big role in patients with irritable bowel syndrome. We know that dietary changes, especially fiber, can make a big difference, especially in individuals with constipation predominant irritable bowel syndrome. We advise at least 20 grams of fiber a day. So just having, a little bit of salad here and there every other day usually doesn't cut it. Using a bulking agent such as external fiber, flaxseed, metamucil, psyllium, those kind of things are generally recommended. And gradual changes to avoid bloating, abdominal discomfort is advised, because if you start on a very high fiber diet, you might be trading one problem with the other, treating the constipation but causing the bloating. Gas-producing foods generally discouraged, and those are usually your brown beans, Brussels sprout, cabbage, cauliflower, raw food, raw onions, grapes, palms, and raisins. We try to decrease some of the fruits that are high in fructose, and we discourage taking artificial sweeteners. Yogurt is generally well tolerated in these people. It acts as a probiotic. People used to eat a lot of, especially Greek yogurt. Nowadays, less. So if somebody is okay with taking yogurt, I usually start with there before venturing to some of the probiotics that are available on the market. There are many ways to cope with the symptoms of irritable bowel syndrome. Psychological therapies such as hypnosis, acupuncture, cognitive behavior therapies, and stress management plays a big role. Fortunately, they are not generally reimbursed by the insurance, but very much recommended by the practitioners as some of the ways that the individual can cope with the pain. And non-pharmacological treatments such as relaxation, stress management, and alternative therapies are advocated. So, to wrap things, IBS or irritable bowel syndrome is a very common problem. We have to make sure that we are dealing with the right diagnosis, and that starts by good physical and history, looking for alarming symptoms. So if you're passing blood in your stool, you're having weight loss, you're anemic, you're vomiting, you're having fevers, those are all signs that there might be something more to the story than irritable bowel syndrome, and further investigation needs to be done. Nowadays, we are learning about other conditions that we used to put them in the bucket of irritable bowel syndrome because we didn't know about them. Some of those conditions are something like eosinophilic gastroenteritis, which is basically attacking the GI tract with the immune cells because of an allergic reaction to some of the dietary intake. Generally, these people, we know that they have severe symptoms, they miss days out of work, and for those people, we generally go the extra mile, do the endoscopy and colonoscopy, do special biopsy to rule out these conditions. We have a robust study about the eosinophilic gastroenteritis, and we are learning that people with this condition have been labeled generally from 8 to 10 years with irritable bowel syndrome before making the accurate diagnosis. So if you have a similar condition that is really affecting your life, there are other things that we thought that are all irritable bowel syndrome, but now with the help of the science and learning about these conditions, we can know about them, make a diagnosis, and there are actually treatments available that pharmaceutical treatment that can treat those conditions. There is no single therapy that has been found to be effective for all IBS patients. I tell them that I wish I had that magic wand that I can, just swing and make you better. But we generally ask, what is your prominent, most bothersome symptom? Being constipation, pain, nausea, bloating, and trying to target that and hammer that with medication, psychotherapy, and other means that we have. And I cannot emphasize the role and importance of the non-pharmaceutical therapies such as hypnosis and acupuncture and other things of that nature that plays a role in making the accurate diagnosis and treatment of these patients. With that being said, I'd be happy to take questions. That's the last slide from my talk. We are here available to answer some of your questions, but I will give the microphone back to Marsha to go over, or Cindy.
There is one question in the chat so far.
Go ahead. I cannot see. I have to stop sharing to see the question. Is somebody able to read the question for me? Oh, let me bring up the chat and see what we have. Okay. How effective are neuromodulators in treating IBS? How long would the patient stay on those meds? Okay, neuromodulators is one of the treatment options that we have that we use for treating the patients. They work by blocking the nerves that go to the GI tract and decreasing the signal burden that goes to the brain. As far as the symptoms goes, generally people stays on these treatments for years if they respond to it. Sometimes takes a couple of trials to be able to find the best agent that can help these patients. When they respond to it, we generally keep them for years, and then we'll do honeymoon trials that basically take off the medication and see how they react. Lots of people with, over time, life situation changes, people get married, they get more comfortable at their jobs, so the stress factor gets better, they learn how to cope, so we can gradually take them off. But I have patients that have been on the neuromodulators for many years, and we have to keep them there. Is there a hereditary? Okay, so there's a question about the genetics links to IBS. Yes, there is no, it's a very good question. There is no gene, so there are some genes that have been found, for example, for celiac disease, that we know that if you have these kind of mutations, you're more prone to get. We don't have that. Irritable bowel syndrome, as I alluded, it's a very broad spectrum of diseases compacted into one term, or you can describe it as one, basket of disease trying to, but if you really dive into, you can see there are so many different variants of it. And we don't have a genetic mutation that is really, has been defined yet. But when you get to each subcategory, you will see that, for example, IBS with constipation generally runs in family. It's very often you will see the parents have the same mom or dad, and then children have it. So that comes helpful in the making the diagnosis. We have another question about SSRIs. Yes, so the question is, are the SSRIs the same as neuromodulators? Notice that placed on SSRI for anxiety 20 years ago, it also helped my IBS. So yes, SSRIs are used as well as neuromodulators in this situation. That's a good question. The tricyclics and SSRIs are the two main components of immunomodulators that we use for treating patients. And that's the last question I see that came on our chat room. So if there is more questions, I'm still available to answer them. I believe that our research team wanted to bring some of the, talk about some of the trials that we have. So if somebody from research is available, I will pass the microphone to them.
This is Marcia. I'm a media specialist at Borland, and I've been working a lot with the research department. We do have a lot of great studies coming up. They have a Crohn's study with Dr. Misra and Dr. Fleischer, and all of this can be found on our website, ebgcr.com, under the current trials or clinical trials section of the website. They're also, we have a gastroparesis, as well as the IBS study, the EOE study, and you can find more details if you click on each disease, and then it'll give you more information, and you can reach out to us, of course, and we'd be happy to provide more details. And that number is 904-680-0871, or you can email us at research@borland.com. And again, if you visit the website, EBG, there's a contact us form, as well as a section that talks about every clinical trial that's currently available. And we appreciate you reaching out to us today and attending Dr. Lankarani's presentation. And we hope to hear from you soon. And we'll be back in touch with you to make sure you don't have any additional questions. And there is another, it looks like there's a few more chat in there too. It says, I have IBS. My doctor is from your group. And then great talk. Thank you for organizing. They loved it. Thank you, Dr. Lankarani.
Oh, absolutely, Marcia. Yes, and I would like to emphasize again, if your symptoms are really bothering you, you think there is more to the story than just simple IBS, reach to us. We have a very robust research team that looks into individuals with complex situations and trying to at least find out if there is more to the story, if there is any other condition that's causing your symptoms. Some of them we are having treatments for them as available, such as eosinophilic gastroenteritis. So we are available here for you. And by that being said, we'll conclude this talk. Thank you for attending, and we hope that you took something away from this talk. Have a great day.